I need you to definitely post for a culinary person. Surprise me.
Oh, thank you. I was on mute. Sorry about that. I was on the phone with IT and so I had muted out and I didn't realize that. So we'll go back and I see Lisa's on. Lisa Johnson, are you on? So as I was saying, we're going to have a guest speaker today. Lisa Johnson is joining us. We're going to talk about falls in the assisted living. And we're going to go over some changes that happened in Matrix on Sunday into Monday morning. So the first change that happened was our consolidation of our clinical reports. And so they took 5 reports and made it 1. And so you're going to see just a detailed resident care monthly summary report. You'll have it either by levels or by points. So we're really trying to clean up those reports. And then the other one was the monthly care summary by category. So that is a new report that should be now functioning for us. And that should already be out and about. And really with the last 2 days, I just haven't had time to check the reports. We've been very busy with care assist not functioning. So that took up most of my day yesterday and today. And then we also have a new client roster data form. So what they did fix was the start of service dates. And as you know, it's not always census. And So it was either pulling census and the previous one that they made for us, or now it was pulling the last evaluation date. So that was wrong too. So now we're going to manually put in the start of service date, and they will be connecting this and unconnecting the 2021 for the evaluation, but it's not yet ready. They haven't fixed that part of it yet. So hopefully that'll be this week. But if you do go in, I would not update the 2021. I would go over to the forms and look up the client roster 2022 and just start filling those out with the correct start of service dates. And I'm going to show you how to do that real quick. If you go into senior living and you go to your evaluation page, oh, it logged me out while we were sitting here. Hang on 1 minute. So what you want to search for is that initial service plan date that you did on your residence. So this would be my initial, and it was effective on 9/3. But if I go up to my filter for my community, and I just want to see the status, you want to make sure closed is in here if you're searching for old ones. And the type is just my initial. And if I put just my initial closed in all evals, if I go down, it will pull up all my initial reports here. And I can go back for anyone and find the date that they started services. And that is the date that then you will use. Oh, hang on a minute. I gotta move all the pictures. That is the date that you are going to use for your start of services. Right here. And so it's easy to find, and if you have trouble, of course, just reach out and I'll try to help you go through it. But we will have to refill out every roster. It won't copy over. It was not a creation that we did. And that has to be a matrix form because it's a state form. Are there any questions on the roster? I'm skipping over some of this because it doesn't pertain to ours. And then on the work list filter, when you're under that scheduling assistant, you're gonna see now that you can filter down into the actual work list for your staff when you want to try to figure out what day you want a bath or what day you want laundry. And you can now put it right down to team 1 or team 2, what shift, and then of course still the task or whatever. They still haven't made this an Excel spreadsheet, but that is coming so that, you know, if you wanted to kind of print it out and look at it, you could use that for whatever you needed to. But this is a great addition because if you have 100 people on services, the scheduling assistant wasn't really effective for us. It was too much to look at. So hopefully that does help you. And so you can just pick whatever work list. It does follow your Care Assist work list. Any questions on that? And that one is already in the system. So that's really the updates from our last upgrade with senior living. Was the roster. So now we're going to turn our focus on falls. We've had a lot of questions recently on falls and the workaround and, you know, why do I have to do this if I have to do romp? And let's see if Lisa joined us yet. Lisa Johnson, looking for Lisa Johnson. She's still not on. She was on another meeting. It may have ran over. So I just wanted you to know that we listened, we hear you, that there's a lot of documentation processes for falls. We want to try to narrow that down for you. We want to look at our systems and do best practice. We reached out to Leading Age over the last month. We've been going back and forth. We're looking at our surveys. We're looking at what they're expecting us to do. And so we're really trying to clarify the falls process. So just to take a note, ROMP is not a clinical note for the resident. It's a corporate notification. It has nothing to do with clinical charting. And so I don't have control over ROMP or the reasons for ROMP. That's kind of a corporate thing. I want to just put that aside for today. I want to talk about just our responsibility, what we should be doing in senior living for a fall. So I want to be really clear that I have no control over ROMP. And so when we have a fall, we really need to fill out a new fall report. That is your incident report. That's the clinical documentation after every single fall. Does anyone have a question about that, where we go to fill out a clinical fall form? So once again, I'm just going to go up to our demo site. Let me get off of Shakopee. So when a resident falls, and let me take off. Like if you have worked for a long time for Benedictine, we used to do fall events. We now do fall forms, and it's found under the fall section or the forms section under clinical and senior living. When you first log in to senior living, you want to go to a new form, and then you can pick your resident, and you need to pick who you're going to do a fall on. And you come down and you will look for a new fall report. This is your clinical documentation for that fall. Sometimes you'll get this notice that there is one already in existence. That's because this resident fell before and they did not finalize that last form. Again, now I can go up and I can filter and find out, I just want to see my in progress, and I can search for my new fall report, and I can see all these are in process. So I can't start a new one until this one has been finalized. So I might want to check it to make sure everything was done. Once I do, I would finalize it, and so that I can now open a new one. And it's telling me not everything was answered. So as a director of nursing in any of my communities, Monday morning, I'm probably going to come in and see who all fell, so that I can come in and say who's in progress, or maybe I want to see, you know, even if they're closed, maybe I want to see all my falls that were done over the weekend so that I can follow up on anything. And so I could see who all fell. And you can also export that to a PDF or an Excel spreadsheet so that it shows me everyone who fell. And I can easily see and make sure I do have a ROMP on each one. I'm not in the greatest Wi-Fi area right now. I'm at a community, so it's not loading. So we'll just, oh, there it is. I'm a little slow today, so you'll see that it tells me who finalized it, the effective date. I can see if somebody's had a lot of falls, I could kind of use that maybe. And it will go by resident on that form.
Hi.
Whoever just answered their phone, could you mute, please? So again, I want to go ahead and I want to modify a form. I can describe the detail in each of these. So if they're found on floor, that's what you would write. The location is just a drop down. There's notes that you can put in a little more information if it's a day room, but maybe I want to say on the south hall. You have to answer what the resident was doing. We do only have 99 characters, so sometimes you can't write everything, but it's just an overall review of this fall. Who was the physician, who was the family, but the interventions are very important. Do I need to look at their service plan and make suggestions and change it? Yes or no? Do I need to review the service plan? I looked at it, but I don't need to make any changes. Or I've already called the family and I'm making suggestions of safety checks or added toiletings or whatever I need. And if it's declined, I am going to write here all my suggestions and what was declined by the family at this time. They don't want to add services. Once I do that, then we have decided that we don't need to open that evaluation and do a change of condition for that fall because I addressed it here. So the only time we're going to tell you that you have to do a change of condition is because then, of course, I would have to open my evaluation to make changes to the service plan. And then we're going to go ahead and make those changes through our usual process. But not every fall we're recommending you do a new evaluation. It's only if you have to change the services, if you document it through the new fall form. Any questions on that? I see Lisa has joined us. And then of course, if you want to do a clinical note, you can make a new note about the fall. You can go ahead and just say that so-and-so fell, saw her today, still no injury, see fall form of whatever. And then if I want to decide to do another visit because they did have a slight injury, I would just do another clinical note stating saw resident again, still no services required, still looking okay. And then I can close that note. So you're the nurse, you decide how many visits it does warrant depending on what type of fall you have. So Lisa, did you want to pull up the PowerPoint or do you want me to pull up that PowerPoint?
I can pull it up.
Okay, I'll let you share your screen. Hang on 1 minute, I got to. I'll stop share if you want to go ahead and share your screen and then I'll let Lisa do the talking for a little bit.
Thank you.
I did not introduce your title, Lisa, because I couldn't remember it, to be honest.
That's okay. That's okay. Well, I'm Lisa Johnson. I am the Benedictine Rehab Program Development Specialist. And Linda had asked me to join you guys today just to talk a little bit about fall prevention, give you guys some information that you can bring back to your teams and just share with them about fall prevention and fall management. We do have a comprehensive fall prevention program within Benedictine. that was initially rolled out on the skilled nursing side. Unfortunately, COVID put a halt to rolling out onto the housing side, but we did want to get this information out to you guys as we're figuring out how to get additional resources and information into each community. So I will send this presentation as well as some of the resources to Linda afterwards so she can send them out to you guys. Feel free, take this PowerPoint, share it with your associates, share it with your community. It is just a very general information overview. And if you have questions on any of the pieces, want further information, please don't hesitate to reach out. My email is Lisa with a Y, Lysa. If you email any other Lisa Johnson, there's about 4 or 5 of us who might possibly respond. So mine's Lisa with a Y. All right. So when we talk about fall prevention, a lot of times it's really hard to stay in the prevention space. So we really tend to move into that management, that reaction of what happens after the fall, and all of the documentation and information that goes along with it. So I just wanted to start out, give a little background information on falls, kind of why they're impacting us. So you have that information to share with your associates, and then some things that we can do both on the preventative and the management side of falls. Because truly, we don't have to wait for a fall to happen. There are some key indicators of somebody's risk of falling and things we can put in place prior to the fall happening and hopefully prevention of it. So this might be a very common statistics to you guys. Falls are incredibly common. There are over 36 million falls every year, and of that, over 8 million are injury falls. They lead to about 3 million deaths and emergency departments a year. So really, really high risk of falls, especially when you start getting to those who are living in our communities. So there's a lot of reasons that falls happen, but a lot of it is really, we don't talk about them enough. We might talk about them in the clinical space, in the nursing space, but our residents tend to not talk with them to those who really need to know about the falls. They're very, very common, but there's also a lot of reasons that your residents and family members might not tell you that they've had a fall in their past. A lot of them, they really fear losing their independence. There's this fear that we might move them over to the nursing home. And really just this awareness that just because you are getting older doesn't mean that falls are a normal part of aging. Yes, are there risk factors, especially with those in our communities, that increase the chances of them falling? Of course. You've moved from your home environment, that in itself increases your risk. But there's a lot of things that we can do at the front end and after a fall to really help mitigate those risks. And a lot of it just starts with talking about falls and really taking away that preconceived notion that falls are a scary thing and we can't do anything about them, because there's a ton that we can do to prevent falls. And there's different strategies that we can use throughout kind of the fall spectrum, whether it's prevention of that first fall or prevention of a secondary fall. So part of the thing we also want to talk about is we want to talk about the consequences of falls. We know in the nursing spectrum that falls have a massive impact on our resident quality of life, function, the level of care that they might need. But there's also a large impact to our associates as well. There's the social impact, there's the physical impact. So the more knowledge that our associates working on the front line have about falls and why we want to be so concerned with preventing them, the more power they're really given to help us in this prevention of falls. With kind of that fall rates, I'm waiting to see the data that's coming out, the post-COVID data, but there's been about a 30% increase kind of from that 2009 to 2018 spectrum for those 65 and plus. Preliminary information coming out kind of about the past 2.5 years with COVID is really staggering, the increase in that number, especially because of the isolation, the decreased mobility, the decreased socialization, all of which have huge impacts on increasing the fall risk. So some of the things we can do and encourage all of our associates to do when they're engaging and interacting with our tenants and residents is just ask them simple questions. Have you fallen in the past year? Do you feel unsteady when you stand or walk? Do you worry about falling? The statistics around worrying about falling and the impact it has on increased risk of falls is up to 65%. So if you are someone who is worried about falling, you have a 65% greater risk of actually falling, even if you have no other comorbidities impacting it. Because what we do when we are fearful of something, especially something that we may or may not have a conscious recognition of, we begin to limit some of the movements that we do that actually help prevent falls in the long run. So really talking about our residents, talking with our associates to encourage them to have these conversations. So what is a fall? I know Linda's probably gone over this a little bit, but there is a lot of confusion on what is a fall. Typical definition kind of across the spectrum, whether you're in the home setting, skilled setting, assisted living, memory care, senior living, it's an unintentional coming to rest on the floor, ground, or another lower level, but not as a result of an overwhelming force. So if somebody pushed somebody versus somebody tripping and falling. Areas we want to pay attention to are episodes where residents lose their balance, but they don't fall because either we intervened, another individual intervened. A lot of times I will hear residents and tenants talking about, oh, how they stumbled when they got out of the car, or they kind of have a shuffle step and grab onto the table when they're moving their dining room chair out. All of these are things we want to pay attention to, because what prevented the fall was the furniture or the other person. So really looking at those pieces as well. When we get a little closer, because I know some of us, depending on where we are in our communities, what states we are in, we may have surveyors that are coming in who are more familiar with the CMS RAI version language. So it's important that we recognize and understand the different definitions and who's defining what a fall is, especially in those conversations where we might have state talking to us versus family versus a physician, because those may all be different definitions for what they consider a fall. Typically, when we look at a fall with injury, this is skin tears, abrasions, lacerations, superficial bruises, hematomas, sprain, changes in mental condition, or any fall or injury that causes the resident to complain of pain. So as a therapist, when I ask residents, have you fallen? I will also ask them, have you gotten any skin tears, any bruises lately, any change in your thought process or any pain? And then I'll ask them, oh, what do you think is causing that pain? Or, oh, how did you get that bruise? And a lot of times that might be the roundabout way to find out the resident actually did have a fall that was not reported to you. Again, because that fear of reporting a fall and what might happen to their independence. So fall prevention. It seems like common sense. We can prevent falls by really targeting the modifiables in life. And with many adults, there's a lot of things we can do to decrease risk factors. There's some risk factors that we can't do anything about, but the good news is for our community, for our population that we work with, most falls can be prevented. But we just have to have an approach and a plan to preventing falls, and really to encourage our residents, our tenants, our associates to take prevention over management. Management of falls is always going to be part of our life, especially in the senior space, but prevention tends to not be as much. So learning prevention tips as well as post-fall management tips is really crucial to impacting really that workload in your community, as well as that quality of life and safety in your residents and tenants. So one of the biggest things is risk factors. So a fall within the last 6 months is the single most predictive factor of a future fall. If a resident has fallen in the last 6 months, they are 74% more likely to have a fall in the next 6 months. So really important information to have, especially when somebody comes into our community initially. Maybe they move from the skilled nursing side over to the housing side. Maybe they're coming from another sister campus. we want to be asking those questions. If it's happened in the last 6 months, the risk of another fall is monumental. Two quick ways to really identify those potential fallers is just ask them, have you fallen in the last 6 months? Give them a date range. And then ask them about their balance confidence. So what you're asking here is you're really looking for, how do they feel they are when they stand, when they walk, then when they move around. You're looking at that fear of falling, self-perception. If an individual is nonverbal, or maybe they have a cognitive impairment that's impacting their safety, their behavior rationale, and perhaps impulsivity, some key things we can look at is rigidity of movement, expressed anxiety and body language, or excessive reflexive fall reactions. So this is that individual who maybe when you pass by them in the hallway, they grip their walker really, really tightly, they get really, really rigid and firm, and they stop walking. That's a key indicator that this individual either has a significant fear of falling or has fallen in the recent months. So those are some things we just want to be aware of, and we want to be sharing with all of our associates as well, because they're the ones on the front line that are going to be recognizing, talking with these individuals. Our culinary associates, our activities personnel, our volunteers, these are all individuals that might be able to highlight and point some of these things out for you guys too. As I said, falls are common, they're costly, they have serious consequences, but again, they are preventable in most cases. If we look at this chart, it's modifiable and non-modifiable risk factors. The modifiable risk factors are much larger. These are all things that we can impact by either changing medication, changing routine, changing diet, changing mobility, changing environmental considerations. These are all areas where comprehensive nursing assessments and team approaches can find impact. Some of those non-modifiable risk factors, age, sex, race, ethnicity, history of falls. Obviously, if somebody's already fallen, we can't do anything about that, but we can work to prevent the other. Fall rates increase as we age. The older you are, the more at risk you are. Women are more likely to fall and incur injuries compared to men. However, more men tend to die as the result of a fall. And that's just in the type of injuries that occur and the way that our bodies react to some of those injuries. If you look at differences in race, ethnicity, more American Indians and Alaskan Natives who fall compared to others. However, the injury is less in compared to the general population as well. And again, having fallen also increases the chance of falling again. So being able to look at your residents and your tenants when they're admitting to your communities and looking at, okay, is their fall risk modifiable or is it non-modifiable? So one side we can really do something about, and the other, we just have to be aware of it and know how to intervene and how to potentially educate and prevent. Environmental risk factors. So this is an area where I will usually talk about both preventable and management interventions. So these are all things that when I go into a residence room and I'm doing an environmental assessment with them, I'm really looking at what does that floor surface look like? What is the furniture that they have in their home? I talk with family members a lot about the furniture they're bringing in and making suggestions, especially if there's somebody who's on therapy currently. These are things we're really looking at, but things for you and your team to be aware of to prevent that fall, as well as modify the environment after a fall perhaps occurs. Trip hazards, we're aware of those. Footwear. I will talk about when I do education, grippy socks. A lot of times I see grippy socks as a very common intervention. And in housing, a lot of times it's slippers that people wear. We just tell them, put something on your feet. But I don't know if any of you have taken a peek at somebody's slippers lately. Usually the grippy pieces aren't that grippy. A lot of times they slide. Sometimes we have people wearing Ted hose, compression stockings in them, which make them even more slippery. So footwear can make a huge impact, especially when we're going in and out of the room as well. Some quick safety tips. It's secure, light, have a seat, clear the way, and store things away. These are some quick tips that I will give to families and residents when they say, how can I make mom's home safer? Or how can I prevent a fall for mom? What should I do before mom comes back from the hospital after falling? And those are just some quick tips. There's also things that you guys can put in place as interventions in collaboration with the families and the residents. Some quick screening tools. These are things that I will work with my associates and my therapists and family members just to talk with the residents. This obviously doesn't cover the stuff that Linda had spoken about earlier, but these are some tools just to get you started in that fall prevention space, recognition of fall risk within your residents. Have you fallen? Do you feel unsteady? Do you worry about falls? If anyone's answering yes to those 3 questions, we want to dive a little deeper and figure out what is impacting the falls and maybe pulling in some additional parties to help further assess and individualize a care plan. All right, so fall intervention. So what do we do after the fall occurs? This is always the common question because it seems like we kind of have a go-to list. Escort the resident to the dining room, toilet checks, call light, attendants, put their walker close by. But there's a lot we can do with interventions after a fall has occurred to help prevent the next one. And some of them are kind of blanket things we can do, whereas others are very specific to the individual. So finding the root cause of a fall and further investigating and looking into it can really help us with this. I know that we are super strapped with time in our days with our interactions. So sometimes a fall intervention might be just getting an additional party in to assess fall risk and what interventions can go into place. So that in itself might be an intervention that your team uses. Fall interventions for fall evaluations. So your therapy teams are versed in fall intervention and fall evaluations. Some of the things, the key indicators that we will talk with team members about is if you're seeing any of these physical changes, refer to therapy before the fall occurs. Oftentimes we talk about these things after the fall occurs. Decreased ankle motion. So these are individuals who maybe they can't get their socks and shoes on really well. They need a lot more assistance with that. Decreased hip range of motion, somebody who's not able to stand upright, or maybe they can't lay flat in their bed. If they are taking more time to get to the dining room, to get to the activities room, to get to chapel, that increased time and not an increased distance may be an indication of leg weakness that's beginning to occur. Anytime there's pain, if somebody's in pain, they're automatically at an increased risk for fall. So an intervention that mitigates pain goes a long way to prevent the next fall. Incontinence. If you have individuals who are on toileting checks, who have nocturia, frequently getting up at night to urinate, these are individuals who probably have had falls near the bathroom or attempting to get into the bathroom. I would highly encourage having a therapist, urologist, and comprehensive assessment in that fall prevention in the space of urine retention and urge incontinence. Loss of balance. Just because you don't fall and somebody's there to prevent it doesn't solve the intervention. A lot of times when I read interventions, they'll say walk to dine, assist resident to the dining room, physical assistance. Well, that's great and fine and dandy, but that doesn't prevent the fall moving forward. Once that intervention is no longer there, or maybe the family decides they don't want to pay for that escort service, the risk is actually increased because we did nothing to prevent that loss of balance moving forward. So kind of thinking about those interventions as well as when we put them in place and when we take them away, especially when we're talking about that escorts and additional assistance with ADLs. And changes in cognition. That's always a big one. I do have another slide that will talk about cognition specifically. Obviously, in many of our communities, we have individuals who are living with mild cognitive impairments all the way to moderate to severe dementia with diagnosed cognitive changes. Cognition has a massive impact on falls. So when we're looking at fall management, when we're looking at fall prevention, some of the things that we might want to address is how cognition impacts all of these areas. It's one thing to give somebody a new walker. It's another thing to have them remember how to use it. Same with a call light. A lot of times we'll say, all right, we're going to give the resident a call pendant. Well, cognitively, after you leave that room, can they identify how to use it, when to use it? Do they have the attention and the executive functioning to recognize its use and when it should be used? Room changes. I know lots of residents who have family members that like to come in and change their furniture around. That's going to be something we want to address because sometimes people can't process either the visual perception, depth perception, spatial perception, or they have learned to pathfind or furniture walk around a room. And when we make those changes, we've all of a sudden increased their fall risk, even though we're trying to prevent a future fall. So really getting a collaborative approach to look at some of those things as well. I will send these out. It's going to be 2 slides, but I will send these out as well. These are just possible interventions that you can use in your community. I did break them down as well by category. So if for some reason, fatigue. So if a resident's really tired and they tell you, well, I fell because I was just really tired. Okay, here's some things that we might do to address or put in place as an intervention. Maybe we encourage resting periods. We have them doing paced activities and coordinate with activity or wellness and family members. Maybe they go to our exercise programs. Maybe if they're somebody who fatigues after meals, we encourage them to wheel versus walk back to their room. Mobility and gait areas, poor decision making. How are we reminding our residents to use these interventions? Some other areas might be in medication. Have we done a pharmacy med review, especially if we have those individuals who continue to fall, or families who do a lot more med management than we do, suggesting a pharmacy review in geriatric fall prevention might be an intervention that we use. If it's somebody who maybe we're managing their medication a little bit more closely with an in-house pharmacist, in-house physician, we could talk with them about some of those side effects of the medication. Maybe we look at non-pharmacological interventions. Many of our residents are on cardiac medications and pulmonary medications. Both of those medication sets tend to have a side effect of postprandial hypotension. So basically, every time they get up after eating, they're at a higher risk for falls. So knowing that if that's somebody who's on that type of medication, maybe we should be encouraging some additional support after meals, or encouraging them to hang out in the dining room longer. Maybe we systematically have our activities team come into the dining room right after that meal to have music time so everybody can digest, and then it doesn't specifically call out those who have these medication interactions and side effects. Some individual areas, if it's just a history of falls, a lot of times we'll see changes to the physical environment, but we want to make sure with those we're not unknowingly impacting and increasing the risk for falls. So making sure that we do have that coordinated assessment with physical therapy, occupational therapy, speech language pathology, with our dietitian, with the physician, if family will allow those things or the resident will allow those things. They're great resources within your communities. Another thing to look at is environmental interventions. I talked a little bit about those quick 5, but other things, have your residents and tenants go through their environment. There's self-environmental checklists that residents and tenants can use, families can use, especially those who maybe aren't on as many services as we would recommend. We can encourage them to self-identify, and perhaps that's the first step in further interventions for them. Again, I will send out this resource, but these are just some of the areas that we could be impacting throughout our community. And then just a few additional resources for you and your team. STEADY is the CDC program for fall prevention. It does have a lot of great free tools. This is what the Benedictine Fall Prevention Program was based in. Their program has stuff that you can use on the independent and assisted side. That way, we're encouraging our tenants and residents to be involved in their care in fall prevention. So if it is that resident, I know Linda was talking about earlier, where you have a recommendation, you'd like to make a care plan change, but the resident, tenant, family members, they know we don't want to go that way. Maybe this is the intervention we say. We're going to provide them resources from STEADY and encourage them to really be proactive in their fall management until they come to a point where they're deciding to take our more further involvement. I love this screening tool. This is a tool that I use with all of my residents I work with before they transition from our TCU settings into the home setting, into the assisted living setting. But it's a self assessment, a self screen, and it really helps open up those questions. I encourage residents to bring it in with them to their next physician appointment, or when they're going in to see a nurse or any other family member and medical provider. This is also available on that STEADY website, but it's a great way to just get that conversation started, if not between you and the individual residents, between the residents themselves, because the more we're talking about fall prevention, the more we're able to prevent falls. And then here's just some additional resources. All of these are free to use. They're all available, whether you're a provider, family member, tenant, across the board. So this will be sent out. You'll have all of that information available. There's also some great CEU education on here that you guys can use, and it's free within the healthcare provider resources too. So I just wanted to include those pieces. All right, I'm gonna stop my share.
Lisa, that was really good, because I think one of the frustrations the nurses have is trying to think of interventions or a different way of thinking about a fall. And they say, well, they just always fall and there's nothing more I can do about it. And I think just seeing like all the different avenues we could really go down to help our residents not fall, I just think it was very, very helpful. So hopefully, you guys thought so too, who's on the call.
Thank you. Yeah, and you know, one of the things I would say is when you guys are working on fall interventions, don't think you have to put a million interventions in there. Start with one. Then you know if it works or not. And if it doesn't work, we can move to a different one. A lot of times we tend to put, I think on average, we have 7 fall interventions. And if it's not working, we don't know which one it is. So start small, start with one, see if it impacts, and then you can, as a team, make that decision for a different one.
Do you guys have any questions for Lisa or any comments? Go ahead and unmute if you want. Okay, well, thank you, Lisa. Thanks for joining us today. I think it's hard for them to understand the difference also between the documentation in Matrix versus the documentation in ROM. I
Yes.
don't know if you have any more insight to that, because you've been with Benedictine a long time. Do you want to comment on that at all?
You know, I think the biggest thing about ROMP is it does allow you to get additional resources from the support center and from our group. When those ROMPs are completed, there are notifications that go out. So especially if you are having some additional challenges, that's a great way to let us know with the ROMP reports. And then I tend to, when I'm filling out some of my reports that I need, I kind of have a blank list of my fall interventions that I might plug in. I keep those resources in place. That way I'm not having to reinvent the wheel every single time with those pieces. So, and you know, if you're struggling with the documentation, if you guys aren't sure what interventions to put in place, reach out to your therapy team too. You know, they went to school to work on fall prevention, so they are a valuable resource for your team.
Yeah, I do think we kind of forget that. In the pharmacy review of medications, I think that's really a biggie, that we are very polypharmacy and sometimes we just don't get that done. So
yeah,
well, I hope
I can include that in my resource too. There is a medication quick sheet that we had from the skilled side that I could include when I send you the resource packet, Linda.
Perfect. Thanks. I really appreciate this, Lisa. I think it's helpful to hear from good resources that we have at Benedictine to help us with falls, and hopefully we can help manage that a little bit better and help you guys. So
definitely. And if you guys need anything, reach out.
Perfect. All right, well, that's about all that I had for today. Does anyone have anything else they want to talk about? Anything else on anyone's mind?
Just where do we find that false PowerPoint that we just saw? Or can we?
I'll be
that
sending it out to you.
Oh, okay,
Yep.
thanks.
And this is a recorded session that'll be on our Matrix Care Senior Living site in eSource. I'll put the recording on in the next couple days for you, so you have that reference also. Great. Well, thank you guys for joining. I'm going to give you 7 minutes back to your day, and I'm going to get back to our survey here at Osseo. So everybody start wishing us luck in this building. So talk to you all later. Thank you.